Hey everyone, good morning. If you can hear me, let me know. So we can get started here in just a few minutes. Hey, Kadeen. Hope I'm saying that right. That's how I've been saying it in my head the past few emails. Oh, good. Hello, Joshua. Hopefully traffic won't be too bad for everyone this morning, rolling out of bed. And I think we left off on the pediatric section, so that's not the case. Let me know and I'll try to catch myself back up. Of course, if you have any questions or anything, feel free to post them up. Hey, Andre. I finally got like a photo roster of you guys, so I can at least place some faces with names now, even though we can't meet in person, so that's helpful. I think we just have a couple more sections left together for the exam, so getting close to the end here of the semester. Yeah, I just think 2 more sessions. I'm up to 10 people so far. Hopefully everyone will join us today. Of course, if you have any questions or anything, feel free to post them up in the chat. Of course, we'll address them whenever they pop up. And then always a sticky board. Always use that since it's a pretty handy tool, I think. How's it going? I'm going to say Brile. Is that how I pronounce that? If I don't mess up anyone's pronunciation of their name. Oh, good. 2 for 2 today. That's fantastic. Hey, Mina. Hello, Nisha. Starting to get a few more people in here. And Valerie, how's it going? Hopefully, is that some fun weekend plans? Probably studying for an exam or something, I would imagine. And can anyone confirm this is where we left off at the pediatric section? Pretty sure we did, but let me know if not. All right, cool. Thank you. All right, well, it's 8 o'clock. Let me go ahead and start the recording here just in case anything totally dies on me. All right, well, thanks for joining me this morning. It's another Good Friday. This is our second to last session here, so If you recall, last week we were talking about geriatric pharmacology. We were talking about, their assessments in terms of like how we're judging organ function and things like that, how we're interviewing them to get a good idea of what medications they're taking and all of that. Well, now we're going to switch gears here a little bit into the pediatric pharmacology. And so, it's a common saying that, they're not just little adults. And really, they're a very heterogeneous population. And what I mean by that is that they change very much from patient to patient, such that, a 1-month-old is going to be acting physiologically very different than a 16-year-old, very different than a 4-year-old. And so because of that, it's important to take into account all these like really age-specific considerations in terms of their pharmacogenetics, because they are quite so different. And the other big challenge too is that a lot of times it's difficult to do good research in children because, again, they're sort of a protected group when it comes to research and doing drug studies and whatnot. So sometimes you may find that we're actually just back extrapolating adult data into children, which I just said they're not little adults, and so that can be difficult because sometimes it's not going to be a one-to-one sort of transition between those two populations there. In terms of some of the lingo that we're going to be using here, and I'm going to focus a lot on the neonatal and the infant sort of period, as we'll see here in a moment, because that is where you're going to see the biggest changes in terms of physiology. That's where we're going to see the biggest changes in terms of how we're going to be dosing drugs differently, or how we're going to be using them differently for this patient population. So one of the big things here is going to be gestational age. This is basically the maturity at birth, and so you're basing that off of things like the last menstrual period and also actual physical exam, the size of the baby and things like that, or the fetus as it's developing. And then you have the postnatal age. These two are going to be sort of the most important numbers we're going to be using here when discussing this, especially in the early periods of life. This is not so important, if someone's like 16, don't necessarily know what their gestational age is, but certainly very early on in life, this is important. There's a post-conceptional age, which is the two together. I don't use that too frequently in terms of medication management for these patients. In terms of looking at their gestational age, we're going to consider anyone preterm to be like less than 37 weeks gestational age, full term being like 37 to 42, and then post term anything greater than 43. Again, this term is not quite so important for my purposes. I really want to know, especially the preemies, how preterm they were, because you're going to find that this has some big implications in terms of how just mature their organs are when they come out into the world. When I say newborn or neonate, that's referencing the first month of life, the first 28 days or so. Newborn, neonate are synonymous with one another. And then infant's going to be basically that first year of life. So you may hear me refer to a newborn as an infant. That is technically true. So all newborns are still infants because that's really that first year of life. But not all infants are going to be a newborn or a neonate. So if you have like a 6-month-old, I still call that an infant, but they're certainly not a neonate. So a little bit of distinction there. And so that'll be important too when you're talking about specific drug dosing. You'll see when you're looking at some of your drugs, you may have noticed this too, like in the pediatric section, you'll see there's a neonatal section and then there's a pediatric dosing section. So those two are important to make distinctions because, again, they are quite different, as we'll see in just a little bit. Then you get into things like toddlers, which are about 1 to 2 years of age, young child, 2 to 5, older child, and adolescent. You're going to see here that as they get older, this is going to make less and less of an impact in terms of their physiologic difference, because at some point they will start to mature up in terms of acting more like an adult and some things like their distribution and their metabolism and all of that. And one of the big handy rules of thumb for pediatrics too is you're going to see that when you're dosing for them, and you'll see this a lot in pediatric dosing, we'll say like, do this many milligrams per kilogram. Once you start butting up against adult-sized doses, you're generally going to cap that out. So, for instance, if an adult max dose of ibuprofen is 800 milligrams, and let's say I have, the normal dosing for ibuprofen is 10 milligrams per kilogram. Well, if I have a kid who weighs 85 kilograms, I have a teenager who weighs 85 kilograms, I'm not going to give them 850 milligrams. I'm just going to cap it out the adult dose. So you're going to see at a certain point, you just start kind of treating them like adults as they start to get more functionally mature, especially into their teenage years. Now, we're going to look at some of the differences here in terms of physiology. And so we'll cover each of these points as we go forward here, but this is kind of a handy set of graphs to come back and look at to get an idea of the differences in terms of their pharmacokinetics, whether it be from their gastrointestinal function, whether it be from renal function. All of this is going to be really different, especially as you will see in the very early stages of life, that NICU sort of period, or that neonatal period. And of course, when I say NICU, I mean the neonatal intensive care unit. That's where I'm most familiar with dealing with neonatal patients. As I've mentioned, I work at Memorial Children's Hospital, and so we have a NICU there where we see a lot of pretty sick kids that get transferred into us from other institutions, since we don't actually birth them there at all. But let's look at absorption. Let's look at the first portion of the pharmacokinetic, the ADME. We're going to look at absorption first and see how that differs in pediatric patients. And so, of course, a lot of this is going to be dependent on the physiochemical properties of the drug, which we've talked about already. And you're going to see things like molecular weight and particle size. All of that will be important in terms of how easy something can cross membranes. We'll talk about GI, certainly, but also you want to think about from the integumentary side. So you want to think about the skin and how that is going to be different as well, as we'll see in a little bit. pH and pKa we'll talk about briefly, how that might be different in our neonatal patients, and then looking at the dosage form that they're administering. And so, which route of administration we're going by, which dosage form we're using, whether we're using liquids and things like that, will play a role as well. And so I'm really going to focus also on that anatomical physiologic characteristics and how those are different. So in terms of gastric absorption, we'll start with this one first, because this is probably going to be the most common way you're going to be administering drugs to patients here. You're going to see two of the things that really affect GI absorption is going to be gastric acidity in the GI tract, and then also this gastric emptying time, or basically you may see like gastrointestinal transit time as well as another term for this. So how quickly are things moving through the GI tract? And this differs greatly between, say, an infant and an adult patient. Typically, what you're going to see with gastric absorption and pH is that very early on, especially the first, say a month or so, you're going to see some big changes here. And so initially when the baby comes out, that they're actually going to have a pretty neutral sort of pH in the stomach. You may find gastric pH is like 6 to 8 in a full-term infant. And the reason for that is because when they are still in the womb, they don't really need to be producing stomach acid. They're not actually consuming anything, at least intentionally. There will be some passive sort of swallowing of amniotic fluid, and so that's actually what's going to be leading to that sort of neutral pH. And then as they are born and they are starting to process food, whether it be breast milk or formula, whatever, you're going to start to see the acid content actually start to peak up. It'll be highest within that first week or so when they're trying to sort of get that pH down, and then it will sort of level out. And so by 3 months, they should be pretty close to adult levels here. But what's interesting, and you'll see this kind of across the board, is that in preterm infants, their organs just aren't as mature as a full-term infant. And so, and again, normally like the youngest you're going to see in terms of gestational age is probably 24 weeks. It's rare to have anyone younger than that, just because they're not really mature enough to really handle being out in the world. But if you were to look at a 24-weeker compared to like a 38-weeker, you're going to see that their GI tract just wasn't ready, right? They needed more time in the oven, so to speak. And so don't put babies in ovens. That's a really bad idea. But you're going to see here that the pH is going to take even longer for them to sort of catch up because of that feature there. But overall, what we're going to see with drug absorption is that because they are going to have a more basic sort of GI tract, especially early on, or if they are physiologically immature because they're premature, you'll see that acidic drugs will have a harder time being absorbed. You're going to have that decreased absorption there. And then for basic drugs, they actually have an easier time getting absorbed. And this kind of goes back to what we were talking about previously with pH and pKa. Remember, like dissolves like, and allows those drugs to have easier absorption. So I won't belabor that point too much. But what we're going to see with the GIT, or this gastrointestinal emptying time, is that this is going to be determining that rate of absorption. And so what you'll notice, and if anyone of you have children or been around young children, you will see that their GI tract is pretty sped up, especially early on in life. And if you were to look at, say, like bowel movements of an infant, they can have 6 to 8 bowel movements a day in some cases there. So things are moving through fairly quickly, which means that drugs actually have a shorter amount of time they're going to be in contact with the GI tract. And so less time in contact means less chance for absorption there. So you may see the actual the actual total amount of absorption may be diminished here. But you'll see there could be some things that will change this, right? There can be things that will maybe diminish and slow down the GIT in some cases here. So you're going to see, for instance, if I have any conditions which will decrease blood flow to the GI tract, well, that's going to slow things down. So if you had someone like congenital heart disease, if you had like a tetralogy of Fallot or anything like that, that can slow down GI tract blood supply, and that's going to slow down the intestinal time. Type of feeding can be a factor here, whether they're breastfed or formula fed. Gestational age, postnatal age, all of that factors into it. And, Dr. Levine can get into that in much more detail than I'm going to get into here. So if you have further questions, she's a really good resource for that too. Because, she's a PICU attending. She knows what she's talking about. But as I mentioned, you may find that certain dosage forms are not great for this really young age population because their GIT is so quick that you're going to find they may have incomplete absorption there. And actually, this may account if you're given even two children who have the same weight, but maybe were born at different gestational ages that account for changes in GIT. You may actually find, even though they're getting the same dose of drug, they can have different serum levels that could be measured there because of that change in the total amount of drug being absorbed. So there can be some changes there for sure. Let's look at the extraoral drug absorption. Let's look at things like if we're going to do IM administration or transdermal administration. These will be some things you want to be looking at here and how that's going to be different depending on the age of the child here. And so you can reference back to this, but I'll kind of cover these as we go forward. So let's look at intramuscular absorption first. You're going to see that several different factors play a role in how well drugs get absorbed here. Now, of course, once you put the drug in the muscle, it's there. The bioavailability is roughly 100%. But you may find that it's very slow to get absorbed into that systemic circulation. So the onset of action of the drug may be diminished, which may or may not matter depending on the drug and you're giving and how quickly you want it to work. But what you're going to find here, some things that help out with intramuscular drug absorption is going to be blood perfusion to the area. More blood flowing through, the more absorption, more quick the absorption is going to be, how well that drug can actually penetrate through those capillaries, and then also that apparent volume. So volume of distribution comes into play here as well, and we're going to find that the distribution is pretty different in especially neonatal patients very early on. We're going to see they have a lot of extra body water, and so I kind of equate them to sort of being like a big water balloon almost, and that'll bear out when we look at the distribution in just a little bit. Overall, though, what you're going to see in neonates and infants is that they're going to have a relative decrease in blood flow to the muscles, and they're going to have a larger water percentage in the muscles as well. So this kind of increases the volume of distribution. So it takes longer for that to sort of, for those drugs to equilibrate out back into the systemic circulation there. And you're going to see overall decreased extent of muscular contractions as well. So if you are familiar with infants, they are pretty much kind of blobs when they first come out. They don't really move around a whole lot. Usually you're going to be wrapping them up as like a little burrito. And so, yeah, that makes sense. They're not getting a lot of blood flow to the muscles because they're not moving them around a whole lot. Not only that, but they're also have a tendency to get fairly cold. They lose heat because they can't really control their temperature very well, especially due to this vasomotor instability. That's why you got to wrap them up. That's why you got little hats on them, because they tend to get cold and dissipate a lot of heat because they can't really regulate that very well. So overall, this means you're going to have a more difficult or slower time for absorption of those drugs from intramuscular administration. In terms of rectal absorption, this is actually a really good way to get drugs into the system if a drug is capable of doing so. So you see this a lot for drugs like acetaminophen when we're trying to give drugs for fever to an infant. You might do this. They may be less than amenable to oral administration. They might try to spit it back out at you, but rectal administration, they don't really have a lot of they usually don't put up a whole lot of fight with this, as opposed to like an adult patient. But if you look at it, the membranes there are quite thin. It's highly vascular. You're going to get pretty good translocation of that medication there. So this can be a viable route. But keep in mind, though, we talked about their GIT being fairly short, and they're going to have a lot of rectal contractions. And so they may lead to them actually spitting out the suppository too soon. And so there's been, a number of, parents who will say, yeah, I gave the suppository, put the diaper back on, and then I took the diaper off later, and then I saw just a melted suppository in there, because basically the kids had just like kind of spit it back out essentially. And so we'll have to do things sometimes like insert the suppository, hold their little cheek shut, and give it time for it to melt and actually absorb there in the rectum. And so that can be one thing you want to think about depending on the age and how often these kids are having bowel movements. So let's look at some other routes. Let's look at, say, for instance, intraosseous absorption. This is a really handy way to get drugs into a patient, pediatric patient. If you have, for instance, look at the vein size in pediatric patients, you're going to find they're just by nature much smaller than adult patients. Not only that, they're more difficult to get access to. They're a little bit more delicate, and especially if you have a kid who is not perfusing very well, say for instance you're in a pediatric cardiac arrest sort of situation, you're going to find that it is almost impossible to get an IV started in those type of patients. And so this is where intraosseous comes into play, very handy, where we can actually get a needle actually down into the marrow itself, and this actually kind of acts as a non-compressible vein essentially. So I can push medications, I can push fluids, everything is able to go through this intraosseous route, and so this can be very helpful in this emergent sort of situation. So always that should be a tool in sort of the back pocket of your kit there. Another important route of absorption is going to be the percutaneous route, or basically transdermal drug absorption. And so basically when they come out, they're going to have a very underdeveloped stratum corneum, especially as compared to adult patients. And so basically if you were to look back at Fick's law and you're able to look at drug absorption via that route, we would see that the thickness of the membrane was inversely proportional to the drug's ability to cross, or that flux, that rate of flux was going to be inversely proportional. So the thinner the membrane, the better, more flux I'm actually going to have coming in there. And so that can actually lead to some absorption of maybe things you don't want them to absorb. So for instance, if I were to use the antiseptic product betadine, which is an iodine-based cleaning product, there's actually fairly decent absorption there. And so one of the things we'll learn when we talk about endocrine drugs is that iodine, while necessary for producing T3 and T4, our thyroid hormones, you're going to find that too much of it can actually shut down production of T3 and T4. So it can either act as a positive or a negative depending on the dose. And so there's been cases of hypothyroidism in infants due to this absorption, right? There's some other cases too where you can see things like hypoglycemia by using isopropanol baths, or just rubbing alcohol, cases of seizures and anticholinergic symptoms from using antihistamine lotions like Benadryl. So you got to be really careful here, because not only that, but they also have a kind of an increased body surface area compared to adult patients. Even covering a relatively small amount of skin for them is still quite a bit of their body surface area in those cases there. Andre is asking, is intraosseous immediately dispersed throughout the circulatory system, or is the delay significant compared to IV administration? It's not that significant. It is pretty, onset of action is going to be near identical to IV. So if I give a dose of epinephrine IV or IO, it's going to be acting relatively the same at the same rate. So yeah, no difference there. So that's pretty handy. Or if there is, it is minimal enough to where it's not really clinically significant for our purposes. But some other cases here where you can find unintentional absorption. I like this one example where there was a case where they actually had these infants, and at this hospital, one of the things that they would do is actually they would drug test the infants to see if they had any exposure to illicit substances that the mom might have been taking during the pregnancy. And so they had these infants that actually were testing positive for THC, and so they go back to the moms and they're saying, well, looks like you were using THC during the pregnancy, and the moms were saying like, no, we weren't doing any of that. And so they went ahead and then tested the moms, and sure enough, the moms were negative. So, were the kids smoking some joints out in the nursery? Probably not. And so what they actually found was there was a certain lotion that they were using in the nursery there, where they were actually finding that there was some absorption of a compound that actually, to the assay, looked very much like THC, right? And so because of that, they were testing as a false positive, but it was because they have such thin membranes that they were able, or thin skin, they could absorb it much more easily than like an adult patient would. So kind of an interesting case. Obviously, they switched solutions after that, and all of a sudden their kids started testing negative. So happy into that story, but it's interesting how you can have, this ultrakinetics can really play a role, can lead to some interesting situations. But getting into distribution, we're going to see again that volume of distribution is really just telling us how far into the tissues, how extensively does this drug like to distribute out to the tissues as compared to staying more into the central circulation. I think we all have a pretty good handle on it now after that last test, but just to remind you, volume of distribution is based off the dose that we are giving to a patient and then the resultant serum concentration. The reason why I'm going over this again is because we're going to see this is fairly different in our pediatric patients as compared to, say, like an adult. And so you can look here, let me see, changes in distribution sites on this graph here. You can see some big differences. So looking at birth compared to the first few months of life, you're going to see the body fat composition is actually going to be going up as they go up. So even though kids look pretty chunky when they first come out, it takes some time for that to occur in terms of actual body fat. You're going to see that the more important thing here, though, is the total body water and that extracellular water. These are both going to be spaces where the drug can actually go and distribute to. And you'll see this is fairly high early on, and then will dip back down. This will be important. I'll show you some good drug examples of this specifically. But you always think about yourselves as being maybe like 2/3 made up of water. Well, actually, in these neonatal patients, it could be closer to 80%. So there's a lot more water outside of the central circulation for drugs to distribute to, especially the more hydrophilic medications. So remember, kind of the things that are going to be affecting volume of distribution mainly are going to be things like lipid solubility, any plasma or tissue protein binding, and that peripheral tissue distribution. So like, where does it like to go to? Does it like fat? Does it like muscle? And obviously there's a lot of different things that will change this, and we'll talk about these as they become important for specific drugs in later classes. So things like burn victims and edema can all have drastic effects depending on if you're dealing with a more hydrophilic or lipophilic drug. But looking at the newborn infant here, you can see roughly 70 to 75, even up to 80% can be just water in a newborn infant here. And that extracellular water component is also going to be a lot greater, right? So like 40% compared to 20%. So like I mentioned, they're kind of like a big bag of water essentially, because they have so much extra body water for drugs to distribute to. So less fat tissue, less muscle tissue. So hydrophilic meds are going to have a relative increase in volume of distribution, whereas more lipophilic meds might actually have a diminished volume of distribution. Kind of think about it as the size of the bucket of your patients here, with children having a much larger bucket for those hydrophilic medications as compared to an adult patient. I like how this picture here, which is not of my child, has the warning here, hey, kids can drown in these buckets pretty easily, yet they're still making a pretty cute picture out of it. But regardless, what does this mean for us practically? Well, basically what it means is that in order to get the same concentration, especially for like antibiotics or something, if I'm shooting for a certain concentration, I'm going to have to give a bigger dose on a milligram per kilogram basis here than I would for an adult patient. I'll show you some examples of this specifically in just a moment here. So think about the size of the buckets you're trying to fill in terms of how much volume, right? Because the volume is going to be much higher for hydrophilic meds here for these neonatal patients. So we'll look at the drug Gentamicin. This is a very hydrophilic medication. It is one we're going to see used a lot for gram-negative infections, and that'll make much more sense as we get into Pharm 1. This is actually the first thing we touch on is going to be antibiotics, so get ready for that. If you recall, when talking about volume of distribution of drugs, anything less than 1 is considered to be more hydrophilic, likes to stay in the central circulation, as compared to things that are greater than 1 liter per kilogram tend to have a high volume of distribution. So looking at this, you can see the Gentamicin, depending if you're dealing with a neonate with that first month of life versus that first year of life or so, and then into adolescents and adults, the volume of distribution is much higher here because there's more water for that drug to distribute to as compared to, say, an infant and child, and then all the way down to an adult. So to get the same concentration here, right, because my volume of distribution is up, and I know my C0 wants to be the same because I'm shooting for a certain target to kill those bacteria, that means I'm going to have to give a bigger dose in order to account for this larger volume of distribution. I'm trying to fill that bucket, and I have a much larger bucket to fill, so I need a bigger dose to do that. And if you can compare the doses here, you can see 4 to 5 milligrams per kilogram as compared to just 1 to 2. These will achieve the same concentrations based on these differences in volume of distribution. So that's why sometimes it may look like you're giving a really big dose to a pediatric patient based on their size as compared to an adult, but really that's appropriate based on the fact that this is a hydrophilic sort of med. Also, you're going to find that developmentally they may be lacking certain things like plasma proteins. You may find that they have different products that are competing for the same sites on those proteins. So for instance, it may have a high amount of bilirubin that is binding to certain endogenous proteins. I'll give you a good example of a drug called Rocephin or ceftriaxone. Rocephin's a brand name. That's another very common antibiotic we use for a wide range of bacteria. And actually, we cannot use ceftriaxone in the first month of life, basically because it actually competes for the same tissue or the same plasma protein binding sites as bilirubin. And so what happens is the ceftriaxone will come in, will kick all that bilirubin off of the protein, and then now all of a sudden you have all this extra bilirubin around, and the kid gets jaundice, right? And so that's why we don't use that drug in the first month of life or so. Another good example, though, is again, we mentioned this before, phenytoin's highly protein bound, like 90% protein bound, 10% being physiologically free and active, or being not bound to proteins, physiologically active. And what you find, though, if you have decreased protein binding, overall you may have a higher free fraction of that drug, which may lead to those more exaggerated sort of effects, right? So maybe 20% is now free, and you're getting double the pharmacologic effect that you were really expecting to see. So this can play a big role in determining which drugs we're using in some cases, or how we're going to modify the dose to sort of account for that. Here you can, and don't memorize this slide at all, but I just want to give you some examples of how these protein stores will change over time. Some of these may actually be increased, or some compounds will be increased, but overall you're going to find relatively reduced levels of things like albumin, globulins, and things like that, but they should get to relatively normal levels as they get closer to sort of childhood. So out of that first year of life, they should be pretty close to adult levels. So switching gears, talking about metabolism now, we're going to see that in terms of metabolism, what will affect that? Well, certainly gestational age and postnatal age are going to be playing a large role here. Again, that's why you can find in some of your pediatric, or more specifically the neonatal dosing, you may find that they will actually delineate how to dose things based off of their gestational age too. And that'll be important when we're talking about how often we're giving meds, and I'll show you an example of that later. But other things that can affect this, things like changes in hepatic blood flow. Remember, less blood flow going to the liver, less drug is being presented to even be metabolized. Overall, the quantity and quality of hepatic enzymes, you may find these may not be all that mature at birth and over the first couple months of life. And then things like enzyme induction, disease states, all these are going to be playing a role overall in terms of how well they're metabolizing medications. So if you recall, we have phase 1 and phase 2 reactions. Phase 1 really trying to modify a molecule to make it more water soluble or get it ready for a phase 2 reaction. Obviously, we remember that the most important one here is going to be oxidation, because that's where our CYP enzyme system is going to be living at, right? So in terms of the CYP enzyme system, we're going to find that when they're first born, a full-term infant, right, that 38 weeks or so, is going to be roughly half of that of an adult. So as you might imagine, they're going to have roughly half the metabolism capability of an adult patient. So that means that drugs are going to be sticking around for a lot longer, right? So if you have, if you're looking at the half-life being a function of volume distribution and clearance, their clearance is going to be a lot lower because they can't metabolize the same rate here. However, you may find that in some cases metabolism can be even better than in adult patients, depending on which system you're talking about and depending on which drug you're talking about. So going back to phenytoin, which is the anti-epileptic drug, we can see here by 1 year of age, they're actually metabolizing at a rate that's 2 to 5 times faster than that of an adult. So that's why you may see that the dose that we're having to administer is much higher than that of an adult on a milligram per kilogram basis, because they're chewing through it so quickly, right? Other cases here, we may find prolonged half-life of drugs. So there's some local anesthetics like procaine, excuse me, and tetracaine. You may find they have decreased esterase activity. It's not the CYP450 system here, but you're going to see this other enzyme system like the esterase activity is relatively diminished, meaning drugs are going to stick around for longer. You may see cardiac toxicity because of this. Or, for instance, the drug theophylline, which will sometimes be used for really severe asthma cases, may have a prolonged half-life, and so you have to take that into account, to where you may give drugs less frequently, may have to increase your dosing interval in order to account for that prolonged half-life. And so looking at the CYP enzyme system here, you can see that depending on which CYP enzyme you're talking about specifically, that these will mature at different rates. So for instance, a couple hours after birth, 2E1 activity starts to perk up. You may find that within the first month or so, you're going to find some 3A4 and some 2C family activity here. Overall, and again, you're not going to memorize, especially even if you work in the NICU, which enzymes are present when, but when you're looking at your drug dosing and you're looking at a neonatal dosing and how it differs from, say, a normal pediatric dose, you're going to see this is why the differences are there. It's due to changes in distribution, due to changes in metabolism, and all of that. Now, in terms of phase 2 reactions, we recall this is where we're actually adding on something to the drug itself. and it looks like I'm drinking some kind of invisible substance there, but just the software ended up removing my water bottle. But anyway, in terms of phase 2 reactions, this is where we're adding something onto the molecule in order to make it more water soluble generally. And so this is where you have like your sulfation, methylation, all those sort of pathways. And again, when they start to mature, it may differ depending on the age of the patient here. So for instance, with like sulfation, they can do that fairly well at birth. And so a good example of a drug that undergoes sulfation is acetaminophen or Tylenol. And so such that if I were to look at, say I'm at the poison center and I have a patient who calls up, or I have a parent who calls up, says that their child drank an entire bottle of Tylenol, I actually have different cut points for when I would send that patient to the ER versus I would for an adult patient, because their sulfation pathway is so good. So as an example, for an adult patient, if they got more than 150 milligrams per kilogram, that's potentially hepatotoxic. I would send them in. For a child, though, I would actually send them in if they got up to 200 milligrams per kilogram. So you can see, extra 33% increase in the amount of dose they'd have to get before I would actually even send them to the hospital. So in some cases, they're well protected because these enzyme systems are going to be more upregulated. Other cases here, things like methylation may not be fully developed, so that may lead to diminished metabolism of drugs. Things like, epinephrine would be a good example of this. It may be slower at metabolizing than you would see in adults. Other good examples, too, include things like benzyl alcohol. Now, benzyl alcohol itself is not a drug, but it actually is a preservative you can find in, especially if you're looking at IV drug products. If it says it's a multi-dose vial, typically it has some sort of preservative in it to make sure that it stays good after you insert a needle into the bottle multiple times. And so oftentimes this includes a product called benzyl alcohol. Now for adult patients, they can metabolize this no problem, and it's a fairly good preservative. But if you were to look at a NICU patient, they can't process that. And so because of that, they end up developing this metabolic acidosis. They get this gasping syndrome, and has led to death in the past. And so that's why if you ever work in the NICU, you never want to use multi-dose products that contain benzyl alcohol, because it can lead to some significant consequences there. So again, most of it is very on a case-by-case basis, but again, your drug references will take this into account. So this is why you see those differences. In terms of excretion, we're going to find that, again, most drugs are renally excreted, and you can see here that all these different factors play a role in terms of how well drugs will be filtered and then eliminated through the urinary tract. And we'll see that depending on the maturity of the child as they're born, this can be very different, right? So dealing with something like a 24-weeker in terms of their renal function can be very different than that of, say, someone who's born at full term. And it can take them some time to actually catch back up. What's interesting, though, is that it can be difficult to really accurately estimate the GFR for a NICU patient, for instance. Now, if you recall talking about creatinine clearance and all of that, things like the Cockcroft-Gault equation, that was really good for adult patients in terms of trying to estimate their GFR. That we had one for more elderly patients, like the MDRD equation. Well, for pediatrics, we have one as well, right? The one that's validated for that patient population. And so is one we have called the modified Schwartz equation we use for pediatrics. But for neonates and infants, it can be quite difficult, especially during that first week of life. They actually have a falsely elevated serum creatinine, and this doesn't really make sense, because you're thinking, well, you just said that they have less muscle mass than, say, an older patient. Why in the heck would their serum creatinine be elevated? Well, think about whose serum creatinine has been kind of floating around in their blood for the past 9 months. Well, it was mom. So oftentimes you can get a serum creatinine when they were first born, and it will look like an adult level, and that's because you're actually measuring mom's serum creatinine at that point. But during the first 2 weeks of life or so, you're going to start to see that renal function start to pick back up. But recall, though, if you have a preterm infant, they're going to have a diminished GFR just due to the fact that they needed more time to mature. But here they are, they're out in the world, and you're going to have this immature number of glomeruli. You're going to have immature proximal tubules, and so it can make it more difficult for them to even filter the drugs, and then whether it needs to be reabsorbed or excreted, it can prove to be a challenge for them. And so if we were to look at, say, like a term versus preterm infants, and again, usually we're going to delineate preterms in terms of how much they weigh when they come out. So again, 2,000 gram, that's a 2 kilogram child, that's 4.4 pounds, right? Versus one's a 1,500 gram child. Looking at their GFR as compared to one another, you can see here how it will naturally sort of increase over time. But even for a preterm infant here at 2 weeks after life, they're still not at the level that they would be if they had been born at term, right? So this can lead to some significant differences here, and that's why if you look at certain drugs, you will see that their gestational age plays a role in how often you're going to be giving it, right? Because if clearance is going to be diminished, half-life is going to be prolonged, and so I can modify that by changing my dosing interval, which is commonly done. So another good example of this is going to be gentamicin, as I'll show you in just a moment here. But looking at GFR as compared to a neonate versus older patients, you can see how it does pick up within the first few months or so, and then by the time they're 6 months old or so, they should be pretty close to adult levels there. Keep in mind, we can't really measure GFR very well based off the serum creatinine early on. So what do we do instead to sort of estimate renal function? Well, oftentimes we're using urine output, right? And so it can be fairly easy to get urine output figured out. Basically, either weighing wet diapers, or you're going to be, if you have a catheter in the patient, you can measure it directly. But we're basically looking at urine output to determine, okay, are they processing fluid through here? Are they filtering? And that can give us a good idea of how well that kidneys are functioning there. But to give you an idea of how well they can filter and clear these drugs, well, gentamicin is a drug that undergoes 100% renal clearance, and you can see how the half-life is quite different depending on how old the patient is. So early on, like say a neonate less than 1 week, their half-life can be pretty variable depending on gestational age, whether it's 3 to 11.5 hours, all the way up to adult patients, which is like 1.5 to 3 hours. And we also said, if you recall, that the volume distribution is much higher for the neonatal patient than an adult. So what does this mean? Well, basically it means I have to give a bigger dose overall in order to achieve the same levels as an adult. But how often I give it is going to actually be quite different, because again, I'm shooting for the same concentration, because that's what I know is going to kill those bacteria. So I have to give a bigger dose on a milligram per kilogram basis here, but I have to give it much less frequently. So what does that mean? Well, like for an adult patient, I may give gentamicin, say, every 8 hours, versus for a neonatal patient, I may give it Q24. I may give it Q36, Q48 in some cases. And so you have to give the patient much more time to clear that out, because of the fact that their kidneys are just not working quite as well as someone who is older. Not only that, but you can see some issues in terms of tubular secretion and reabsorption. Both tend to be fairly diminished during the first year of life, and so that can lead to some issues where they have more difficult time concentrating urine. They may have changes in pH as a result of this. So all of that can play a role in terms of how drugs are being processed through the kidneys there. And so what you're going to find is that there's a lot of diversity in response of how well these kids are going to be responding to the medications you're administering. And so you have to take into account all of these different factors here. So whether it be biological factors, such as how premature they were, take into account things like genetic issues that may pop up here, which again frequently are not diagnosed this early on in life, if at all, and then environmental factors that could be playing a role as well, right? So all of these are going to be causing some variation, and you're going to see that no two neonates may be reacting exactly the same due to all these different factors. So just to real briefly talk about the importance of pharmacogenetics, for instance, keep in mind, though, that when dealing with a child, they may have these polymorphisms that are not readily apparent, right? When does, I don't know if you guys know this, but do you know when a joke becomes a dad joke? It's actually when the punchline becomes apparent, right? But anyway, looking at, for instance, codeine metabolism, this is a drug that is metabolized through CYP2D6, right? Remember that codeine is not active naturally, but when it gets converted over into morphine, that's when it's doing its thing. That's when it's causing analgesia. And so again, when you're looking at this, well, one, if the child's not expressing a whole lot of CYP2D6 early on in life, you may find that they may not get a whole lot of benefit themselves. But what if mom's taking codeine? Well, she can convert over pretty extensively herself. Then you may find an exaggerated response in that child as they get that maybe transmitted over in the breast milk, for instance. But for the child themselves, if they are, say, a slow metabolizer, they may not get a whole lot of good response out of that drug because they're not converting a whole lot over into morphine. Versus if you have someone who is an extensive metabolizer, they tend to get a more exaggerated response. And so those were cases where patients were actually dying because they were converting too much morphine into codeine into morphine and developing respiratory arrest as a result of that. So there's actually a black box warning about that now, leading to the fact that we just don't even carry it anymore at our hospital, and a lot of places have stopped using it for pediatric patients altogether. What's interesting, though, too, is that you can sometimes kind of guesstimate based off a patient's ethnicity who might be a good or poor responder to some of these drugs here. So for instance, if you look at the disease state, sickle cell anemia, well, that frequently affects black patients, right? And so what's interesting though is that black patients tend to have a higher propensity to be an ultra rapid metabolizer CYP2D6. So the patients you may find more frequently on codeine tend to be patients who are sicklers. They have sickle cell disease because they also are the ones that are more likely to be really good responders to codeine in the first place. And you'll learn that sickle cell disease is a condition that frequently presents with very significant pain. They're frequently chronic pain patients due to acute chest syndromes and all kinds of things like that. So if you see that, that's actually one of the reasons why is that black patients tend to respond better to codeine because they're more likely to express the CYP2D6 enzyme in greater amount. Thus, they convert more over into morphine. So little things you may see there based off of many different factors, but ethnicity might be one that could kind of clue you in a little bit. So let's look at how we're going to be dosing medications in these patients here. There are a number of different systems that are available here, some of which will be good, some of which will be less so, and we'll talk about those. But first off, you could dose patients based off of their age. So for instance here, if you were to use codeine, you can see here between like 2 and 5 years of age, you dose it 2.5 to 5 milligrams. They're 6 to 12, 5 to 10, yada, yada, yada. This is easy to use. It's fairly easy to memorize, especially if you're dealing with pediatrics every single day, but it assumes that all children are the same. It assumes that every 6-year-old is identical to a 12-year-old in terms of how they're going to react to this, and we know that is simply not the case. It doesn't even take into account things like pediatric obesity or patients who may be very thin. So because of that, this is limited in utility. You tend to find that it's very easy to overshoot or undershoot how well the drugs are going to work in patients based off a system like this. So not great. Body weight dosing, though, is by far the most common thing we're going to be using here. So basically, when you see this like milligram per kilogram dosing, this is really important. When we get to our drug info assignment, or not the drug info assignment, the drug prescription assignment, which I'll talk about briefly here in a little bit, this is going to be really important in terms of getting your skills down in terms of determining, okay, I got this drug, I'm dosing 25 to 50 mg per kilo per day. How do I convert that into an actual amount that I'm going to tell the mom to give that child or that dad to give that child? And so we'll have lots of experience practicing with our prescription assignments in just a little bit, which I'll talk more about soon. Anyway, so what you can find here is that this is handy because you're actually taking into account that patient's actual weight there in terms of how much they're going to be getting. So very common in pediatrics. Remember, once you start to get up to adult levels, you don't want to exceed that. So even if you have, say a 100 kilo linebacker weighs, a 16-year-old who's coming in, you're not going to dose them more aggressively than you would an adult patient, okay? Some things you're going to see in terms of advantages. Most common, everyone uses this in pediatrics. However, you may find that children have an increased med clearance based on their weight, and so that may lead to some discrepancies in terms of how well drugs may work or not work depending on the situation. So it's not perfect, but it gets you most of the way there for most patients. What you can see, though, especially in overweight patients, again, as their weight goes up, you're going to see that they have more adipose tissue. Muscle mass does not go up proportionally there. And so you may find, depending on how the drug distributes, there is a potential for over or underdosing. We know childhood obesity is a problem in the U.S. especially. And so sometimes we'll have to try to adjust the body weight a little bit to make sure we're not going to be too aggressive for these patients, but we can talk about that in another day. Just know that body weight dosing is not perfect, but it gets you 99% of the way there for most patients. Now, BSA is kind of interesting because this actually takes into account not only the height of the patient, but also their weight. And so you're factoring both of those together as opposed to just using their weight for weight-based dosing. And so this allows us to get very exact in terms of how much drug we're going to give based off of their surface area in meters square. There's many equations that are out there. I'm not going to force you to do that. Just find a calculator that works for most people. The advantages here is that it's going to be very precise, and it limits the potential for overdosing based on weight. Because again, if I have a child who weighs 50 kilograms, but they are particularly tall versus they're particularly short, that's all going to get factored into their body surface area. So even obesity has less of an impact here because of the child's height being taken into account. This can be difficult though, right? Actually measuring the height of a child, depending on how old they are, can be tough. So you can find things like, an infant, actually getting them stretched out to get an accurate measurement, or getting a child to stand still for more than 2 seconds can be tough. Do they have shoes on? All that can be problematic. And again, make sure you're always using a consistent calculator depending on where you're working. If you do oncology, this will be very common for you to use, but this is otherwise you may not see it as frequently. David's asking, does body composition have any effect? It does have some effect, but this is mitigated by using the patient's height as well. So if you have someone who's particularly tall or short, that can play a role into what their body composition is based off of their weight. So if I had someone who's like very tall, who weighed a certain weight versus someone who's quite short that weighed the same amount, you can see their body composition would be quite different. But because this is factoring in their height, this helps to mitigate how much might be over or underdosing them. So very handy, but it's a little bit more finicky in terms of getting the right BSA and then dosing based off of that. So again, mostly going to be in oncology, you'll see that. So let's talk about drug administration for these patients here. You're going to find that in terms of IV administration, site of administration is important. Are you getting an IO? Are you able to get a peripheral vein? Do we have a central vein? Again, when I say peripheral versus central, peripheral means you're using like a vein in a limb. Central just means that I'm using some sort of catheter that is emptying out into the inferior vena cava for the most part. So that may be something like a PICC line, which is a peripherally inserted central catheter. So it may be looking like a peripheral line, but it's actually placed, the catheter goes all the way into the inferior vena cava. But that makes a difference, right? Because one, we're going to see that the volume of the drug we're giving the patient can play a role. So I can't give a liter of fluids to a patient who weighs 1 kilogram. That's just too much volume for them. And so frequently we try to concentrate drugs that we're giving the lowest volume possible that have effects on things like the overall volume composition of the patient there. We may find that giving multiple drugs at the same time can be difficult, especially if they have physical incompatibilities with one another. If they precipitate out, or if you only have one line to administer, it can be difficult there. There can be mechanical and technical issues. So in terms of what sort of ability do you have to even get the IV in the first place? Oftentimes you're going to find in pediatric institutions they'll have like an IV team who are several nurses who are very experienced in getting pediatric IVs, and they're kind of like your go-to team if you're having trouble getting IV yourself. And then not only that, but also look at the therapeutic drug monitoring, which we'll talk more about here in the next section. But even looking at things like drug sampling, if you have a neonatal patient and you're getting a blood draw for labs, and then you get a blood draw for a drug level, and you get a blood draw for X, Y, and Z, you can actually cause anemia in those patients. You can actually drop their hemoglobin by doing all this drug sampling. So there can be a lot of issues here depending on the age of the patient and all of that. And frequently you want to make sure that you're also very exact with how much volume you're giving these patients and then how quickly you're giving it. And so, for like an adult patient, you can just hang a bag on them, let it run to gravity, and that's no problem. Versus for a pediatric patient, would be very exact. And so this is where usually some sort of pump mechanism is used here to make sure we're giving very exact amounts to them. So here's an example what an IV setup might look like for a pediatric patient here, all the way from where the drug is held, maybe like in a mixing chamber, for instance, or this could be an IV bag or something, and then run through a pump where this can be programmed to give a very specific amount at a very specific rate, and that then goes into the patient. So here's an example of a syringe pump we might use for a pediatric patient. This is actually the one we use at Nemours. And the benefits here is that it can actually detect the size of the syringe, and it can then run that syringe in at a very specific rate to give exactly how much drug you want to that patient, how quickly you want. The benefit here, though, with a system like this is that we have a library built into it. So that way, if you want to run in, say, for instance, an antibiotic, it will know what concentrations you have available, and then we'll be able to program that in to give the right dose and everything. The nice thing, too, though, is it actually prevents nurses who are most frequently going to be setting these up to give too much, too quickly, and all of that, because there actually will be limits set into this to prevent them from making mistakes. And we know that medication errors are quite common, and so anything we can do to try to prevent us from making those is going to be helpful here. In terms of oral administration, this is obviously most common, and it is, depending on the size of the patient and their age, it can be quite tough to give tablets and things like that, or even impossible. And so this is why it's important that when you're dealing with liquid medications that you're getting an exact amount. And so measuring devices are really important here. So, most people have probably heard of give 2 teaspoons, give a tablespoon of this. Using actual spoons is a very inaccurate way of measuring that stuff. Of course, if you recall, teaspoon being 5 mLs, tablespoon being 15. depending on where you're getting your spoon from, they may find that they are measuring quite different volumes there. So I always use the example, if you go to Walmart and you get a US spoon, and then you go to IKEA and you get a Swedish spoon, they may be measuring quite different volumes there. This is why dosing syringes can be quite useful. Even the dosing cups you get on a lot of pediatric drugs tend to be sort of inaccurate. I've done some measurements myself and found that even if it went up to the 5 ml line on that little cup, and then I drew it up into a dosing syringe, I got more or less than what I was expecting to get based off of that cup. So that can be tough. Look at the sensory appeal of drugs. Look at the dosage, or look at the flavoring of it. Excuse me, that can make a big difference. I recall when we first were opening up Nemours, we had cherry flavored Tylenol. I'll never forget, all the nurses almost revolted because they said, listen, if we give these kids cherry flavored Tylenol, they're going to be spitting it back out at us, and we're the ones that have to wear it. Get us a grape flavored. And that made all the difference, and made it much more easy for them to actually give medications to those patients there. Not only that, we're also going to look at things like drug-food interactions. Inactive ingredients can play a role. Some kids will have allergic reactions to certain dyes and things like that, so sometimes you have to look for dye-free medications. All of these are going to be playing a role when you're trying to give these medications to these kids. So when prescribing these pediatric patients, here's some things that I think are really important to make sure you're getting down. So when obtain a current weight, parents may not know this. So again, if you can make sure you can get that weight as soon as possible in order to make sure you're weighing these kids and make sure you're getting the most accurate information there. And then always double check with available references. Make sure you look at very specific pediatric information and not stuff that's adult information and you're just trying to back extrapolate it to that peds patient, right? And also, when talking to them, consider, what they understand or don't understand. So for instance, talking to my 4-year-old, she kind of understands the concept of medicine. My 2-year-old, not so much. And so not only that, but also if you're counseling a teenager, that's very different than if you're doing a young child. And again, sometimes the parents or guardians are not going to be much better off than a teenager might be. So you've got to think about how you're explaining these things to them to make sure they're taking it appropriately. So let's talk about our drug dosing calculations real quick here. So I want to give you some examples of this. This is similar to that quiz that we took previously, or hopefully you've all took already. This will be a little bit easier than some of that stuff we were doing there, but I want to kind of walk you through this a little bit to make sure you have a good understanding, because this is what's going to be how we're going to be doing our prescription assignment, as we'll see here in just a little bit. But let's say we're going to be dosing a kid, say 15 kilogram kid with amoxicillin for acute otitis media. We're going to give 90 milligrams per kilogram divided BID. And our suspension is a 400 milligram per 5 ml suspension, right? Why is it per 5 mLs? Well, that's a teaspoon, and that's just how it's been done historically. So our question is, well, how much should this child receive per dose? So how do we figure that out? Well, first off, you have to figure out, okay, well, how much of a dose is this kid actually going to be getting, right? So how big of a dose? Well, I know they're getting 15 kilograms. I know they're getting 90 mg per kilo per day divided BID, right? So first off, I can figure out how much they're going to get per day. So I can say, okay, well, they're 15 kilos. I'll multiply that by 90 mg per kilo per day. They should be getting a total amount of 1350 per day. Okay, well, I want to know what they're getting per dose. So that's what I'm going to actually write on my prescription, how much they're going to be getting per dose. And so I know that it's divided BID because that's in the instructions here. And so anytime you see divided, anytime you see divided, make sure you're looking at the frequency there, because if this is TID, that's going to be very different than if it's going to be BID, for instance. So this is BID, so twice daily. And so you're going to divide that by 2, right? So they should be getting 675 milligrams per dose. Okay, so that's good to know. You can write that on your script, but the parents are not going to be able to do that calculation themselves. You can't assume that they're going to be able to do that. So you got to figure out how much volume are you actually going to be telling that patient to take, because that's what you're going to be putting on the script. You're going to be putting how much volume to give per dose. And so basically, this is where I'm going to use the actual concentration here. A general rule I always like to do is to go ahead and convert this into what the drug is in milligrams per ml. So I would just divide this 400 by 5, and I'm getting a concentration of 80 milligrams per ml, as you can see here, right? So I know my dose is 675 milligrams per dose, and I know I'm going to be using an 80 milligram per ml concentration, right? And again, make sure your units are canceling out when you do this. So I'm going to take 675 milligrams per dose, divide that by 80 milligrams per ml, and what do I get? I get 8.4 mLs per dose. So on your script, this is what you would actually write, is 8.4 mLs twice daily, okay? That way, the parents don't have to think about how to calculate that out. It's easy. They can just measure that up and administer it to the patient twice daily, and then boom, now they got their acute otitis media treated, right? So let's say, for instance, and actually this is a really bad example because ranitidine was just taken off the market, but I'll leave it here just for the calculation purposes. But let's say we have an 18 kilo patient and we're using ranitidine, which is a H2 blocker. Again, this is just very recently, within the past month or so, taken off the market. But we're using for GERD symptoms. Basically decreases stomach acid production. And they're going to get 4 mg per kilo per day, divided twice daily. And the concentration here is 15 milligrams per ml. Well, how much should they receive per dose? I can go ahead and work this through here. And let me see if I put this actually in the notes at the bottom. I did not, so we can actually work through that together. So let's go ahead and do that. I'm going to open up my calculator too. This will be good. So what are we going to do here? So basically we're saying, okay, well, I know it's divided BID. So I can basically say 2 milligrams per kilo per dose. That would be another way I could also say that there. So in this case here, I know they're 18 kilograms. So 18 kilograms multiplied by 2 mg per kilo per dose. So I know they're going to get 36 milligrams per dose. Okay. And now I can go ahead and divide that by the concentration of 15 milligrams per ml. So 36 divided by 15. And they're going to get 2.4 mLs per dose. So on the script, you would say ranitidine, 15 milligrams per ml concentration, and then you would say take 2.4 mLs twice daily. Okay. Pretty straightforward in terms of how that's going to be dosed out. In this case here, I didn't have to divide by 5 because it was given as a concentration already in per ml, so you didn't have to make any differences there or make any changes to that. Now, when dealing with some drugs, you may find that there are combination products. So for instance, here's a drug called trimethoprim and sulfamethoxazole. This is a drug, the brand name of which is Bactrim or Septra. If you ever see that, that's going to be the brand names for that. Very common antibiotic used for lots of things, including cellulitis potentially. So frequently, though, when you have a combination product, this is going to be in a fixed combination. So it doesn't matter how much you're going to give. It's always going to be a fixed ratio between these two here. Okay. And so that ratio here, the suspension I'm using, is 200 milligrams of sulfamethoxazole and 40 milligrams of trimethoprim per 5 mLs, right? So this is always the same ratio. So generally what you're going to find is when you look up these drugs, they're going to dose it based off of one component of that, okay? So you don't have to even worry about the sulfamethoxazole because the trimethoprim is what you're dosing it based off of, right? So this is the pretty common one you'll see being used for Bactrim here. So I have a 12 kilo patient. They're getting Bactrim for cellulitis, and they're getting 4 milligrams of the TMP component, that trimethoprim component, per kilo per dose BID. Okay. Notice how here this is going to be a little different. Before we saw that it's a divided BID. This is already per dose. So here I don't want to divide twice or by 2 because of the fact that it's already giving me the per dose amount. Okay. Last time we saw it was per day. So that's why I had to divide by 2. This time, don't do that because you're going to end up only giving half the dose you're supposed to. Okay. So how much should this child receive in terms of volume for that, right? So basically what I would end up doing, I would say, okay, well, I know my kid is 12 kilos here, and I know my suspension here. Now, again, this is per 5 ml, so I want to go ahead and divide that out. Forget about the sulfamethoxazole. This is not important for our purposes here because I'm dosing it off of that trimethoprim, right? So I know my concentration here is actually going to be 8 milligrams per ml of trimethoprim, okay? So remember that concentration of 8 milligrams per ml. So first, I'm going to figure out what is the dose in milligrams that I need. So I'm going to take that 12 kilos times 4. I know they need 48 milligrams of trimethoprim per dose. And they're going to get that dose twice daily, right? And so now I'm just going to take that and divide it by my concentration, which is 8 milligrams per ml. And then I'm going to get 6 mLs. Okay, and again, you can go back and watch the video to kind of go through that process, but you should be able to do this on paper as well with me and figure this out. Okay, so here, based off of this, you're going to see you're going to be getting 6 mLs that child should be receiving twice daily. Okay, notice I did not have to divide this by 2 because this was already in the per dose amount. So keep an eye on that because that can trip you up if you're not careful. Okay, let's say we have a patient. Let's say, this is a frequent thing that comes into the ER all the time. The mom is saying, okay, well, I'm giving this much Tylenol to my patient, and they may be under or overdosing as the case may be. And so it's your job to figure out, okay, well, how much are they actually getting, and is this an appropriate amount for that particular patient here, right? So let's say the mom comes in, brings her kid into the ER, he's got a fever, hopefully he's COVID negative, but they're 20 kilos, and they've been giving them 2 teaspoons of acetaminophen 4 times a day for fever, okay? 2 teaspoons, if you recall. 1 teaspoon is 5 ml. So I know this kid is getting 2 teaspoons, 2 times 5. They're getting 10 mLs per dose. Okay, so remember that. Write that down in your notes. So a kid's getting 10 mLs of acetaminophen 4 times a day. And the usual dose a patient should get is 15 mg per kilo per dose. So you look that up in your book and you see, okay, that's the normal dose of acetaminophen. The concentration they're giving is 160 milligrams per 5 mLs. Or if you divide that out, you can write that down as well. It's 32 milligrams per ml. I only know that because I deal with this all the time in pediatrics, and so I just know that. But you can divide it out and get the same answer yourself. So is this child being dosed appropriately? Well, first of all, I got to figure out how much they're getting, what the mom's actually giving the kid, and then I got to figure out what they should be getting based off of that, right? So the question is, well, how much should the kid be getting per dose, right? So basically, I'm going to take that kid's weight. I know they should be getting, based off the fact they're 20 kilos, multiplied by 15, they should be getting 300 milligrams per dose. That's what they should be getting, right? Well, let's figure out how much the kid's actually getting there. So remember that 300 milligrams. Well, I know they're getting 2 teaspoons, so they're getting 10 mLs. And I know that they're getting the 10 mLs multiplied by this concentration of 32 milligrams per ml. So 10 times 32. I see that they're getting 320 milligrams 4 times a day versus the 300 milligrams you calculated. Now, in general, if it's within 10% or so, you're good to go. So I would tell this mom, yeah, you've been dosing the patient appropriately. It's probably a little extra, but that's no big deal. We already talked about how pediatric patients are pretty good at processing Tylenol anyway, right? So again, went through that a little quick, but I think you kind of get the idea. Make sure you keep your units straight, though. Follow that along. And again, if you could do that, the quiz that I posted up on Canvas, you should have no problem being able to do this, right? Just keep your units straight. Make sure you're figuring that out. One other thing I want to talk about with pediatrics is the idea of fluid calculations. And so this is really important. If you know how to do this day one of rotations, you're going to be pretty ahead of the curve, I think, as compared to many of your other colleagues. But when administering IV fluids to a patient, you want to know how much to give, because it's very easy to overdo it and give way too much, and that can cause all kinds of issues, fluid overload, pulmonary edema, all kinds of bad things. So anyway, so this is good numbers to remember as I'm teaching it to you now, and I'll probably be hammering this over for the next year or so to make sure you remember this. And again, I am going to have some calculations on the test, so they'll be pretty straightforward, and we'll make sure we activate the calculator for you, so just keep in mind with that. But again, these are easy calculations for the most part. In general, when you're giving fluids to, say, someone who's dehydrated, you're going to give them a bolus first generally, and then you're going to follow up with maintenance IV fluids, right? Give them a bolus early to try and kind of perk back up that intravascular volume to replace what they're kind of missing, and then you're going to give them maintenance fluids to sort of replace what they lose throughout the day, right? We naturally know that we're going to need to replace fluids, and so this is what our maintenance IV fluids do here, okay? So a general rule of thumb is, for most patients, 20 mLs per kilo is the dose you're going to give, okay? So that's one number to remember. And then for their maintenance IV fluids, and again, if you were like admitting a patient to the hospital, this is what you'd be writing for. You'd say, D5NS at this many mLs an hour as their maintenance fluids. This is how you'd write that. And so we follow a rule called the 4-2-1 rule, okay? Basically, what this means is that for the first 10 kilograms of a patient's weight, they're going to get 4 mLs per kilo per hour, right? For the second 10 kilograms, so they got that first 4 mLs per kilo per hour for the first 10. For the second 10, they're going to get 2 mLs per kilo per hour. Okay. I'll go through these calculations here, so it'll make more sense in a second. And then for every kilogram after that, they're going to be using 1 ml per kilo per hour. Remember, we always use kilograms. We're not going to use pounds for any of our drug dosing because we do the metric system around here, right? So that sounds confusing, I know, but what does that actually mean? Well, let's look at it. Say, for instance, we're doing an 8-kilogram infant. Okay, well, I know they're not even going to go past the 4 part of the 4-2-1 rule because they're less than 10 kilos. So what I can do is I can say, okay, well, I know they're 8 kilograms, multiply by 4 mLs per kilo per hour. Multiply that out. That patient, for their maintenance rate, will get 32 mLs an hour. And again, 32 mLs an hour is not a whole lot. It's 1 ounce, basically. A little more than an ounce. So again, it's easy to give way too much fluid to some of these patients here. Now, what would their bolus be? If I want to write for maintenance fluids, they get 32 mLs an hour. What would their bolus be? I can just do 20 times 8, and they're going to get 160 mLs. So you could write for that too. 2 separate orders. You'd say, let's do a bolus of normal saline, 160 mLs over 30 minutes, and then a maintenance rate of D5NS, for instance. And we'll go over different types of fluids later on, so don't get too hung up on that. But know that they'd be getting basically, what is it, 32 mLs per hour. Okay. So let's do another example. Let's look at, for instance, a 1,200 kilogram or a 1,200 gram. That'd be pretty huge if you had a 1,200 kilogram neonate. Maybe it's like an elephant or something. Even that'd be a lot. But let's say we have a 1,200 gram neonate. Well, what's the first thing we need to do here? Well, we recall from previously that we need to convert this over into kilograms. So how do I get from grams to kilograms? We'll just, again, move it over 3 places, the decimal. 1, 2, 3. I know this is a 1.2 kilogram neonate. You got to do that conversion, otherwise you're going to get really large volumes here. So for that fluid bolus for that child, I would just do 1.2 kilograms times 20. What do you get? You get 24 mLs. So again, that is not a lot of volume in terms of a fluid bolus, right? 24 mLs is less than an ounce you're going to be giving that person IV. Well, what would their maintenance rate be? Well, again, they're not even passing the 4 part of the 4-2-1 rule, so I would just take 4 mLs per kilo per hour times 1.2. They're only going to get 4.8 mLs per hour. Not a whole lot of fluid. That's why it's very easy to give away too much. If you were just hang a liter of fluid and walk away, it's very easy to infuse that whole thing into that patient. That's why we use pumps to make sure we're not going to accidentally overdo it, right? Let's say we have a 45 kilogram adolescent now. Now we can use the full 4-2-1 rule here. So basically what we're going to say is that, okay, for the first 10 kilograms of patient weight, I know they're going to get 4 mLs per kilo per hour. So what is that? It's 4 times 10. So I know for the first 10 kilograms of their weight, they're getting 40 mLs per hour, okay? Well, now they got 35 kilograms left over to account for. For the second 10 kilograms, I'm going to do 2 mLs per kilo per hour, okay? So that means 2 times 10. Now they're getting 20 mLs per hour based off their second 10 kilograms, right? So 40 plus 20, we're up to 60 mLs an hour this kid is getting, okay? And then we have another 25 kilograms to account for at this point. So this is where we use the 1 part of the 4-2-1 rule. And so we do that 25 left over, multiply by 1. Now they're getting 25 mLs per hour based off of that. So what do? I take 40 plus 20 plus 25. They should be getting 85 mLs per hour as their maintenance rate. For their bolus, they would be getting 20 times 45. I would give 900 mLs. Most people will probably round up and just do a liter for that patient. So again, for the test, and again, I'm going to give you pretty easy math to do. I'll round off the weights. I'm not going to give you 45.625 kilograms, right? It's going to be pretty easy, but you'll still have a calculator that you can use to complete these. All right, but let's use the 100 kilogram teenager. What do we do at this point? It's the same process for the 45 one, right? So basically what I'm going to do is for that first 10, we do 10 times 4. It's 40 mLs an hour. I'm going to take the second 10 kilograms. There's a 10 times 2. They're going to get 20 mLs an hour for that. And then they still have another 80 kilograms to account for. So 80 times 1, pretty straightforward once you get the hang of it. Add all 3 of these up, 80 plus 20 plus 40, 140 mLs an hour they're going to get their maintenance fluids. What about their bolus? 100 times 20. You could do a max of 2 liters for that patient. Most people will probably start with 1 liter and then give more if they need to, but this would be a totally appropriate answer for that type of patient, okay? So again, practice it. You can make your own problems up for each other to practice on one another, but you should be able to get the hang of that pretty easily there. This is another one just real briefly. So one thing to note as well is sometimes drugs are expressed in terms of concentration. And so being able to convert this over is actually pretty handy, especially if you're working in the ER and you're dealing with things like lidocaine, for instance. But let's say, for instance, we have a 24 kilo patient and they're getting lidocaine 1% solution intradermally for a laceration to the face. So you need to sew up that laceration, but you want to make sure you anesthetize it first. You want to numb it up first. And so you're going to use lidocaine for that. But you want to make sure you don't give too much. And so basically, based off the reference you looked at, that it can get a max of 5 mg per kilo at one time. So the question is, well, how many mLs can this patient actually receive? And you may be looking at 1% and you're like, I don't even know what that means. That's okay, we can figure it out. Basically what this 1% means is it actually means 1 gram per 100 mLs. Again, that's not super useful here. So one of the things I actually do, a very handy rule of thumb I do for this, is actually I just move the decimal place over 1. Okay, so for a 1% solution, it's 10 milligrams per ml. It's a really good rule of thumb to remember if you ever see drugs expressed as concentrations. You'll see this in the OR, you see it in the ER all the time. Handy rule of thumb. For instance, if you see D50, that's dextrose 50%. That 50%, move the decimal place over one to the right, it's 500 milligrams of dextrose per ml. So that works for everything. If you ever see a percentage, just move it one decimal place over to the right, and that's the concentration in milligrams per ml. So now I know this is basically a 10 milligram per ml solution. Okay, so we know that. Well, how much can this patient receive at a max dose? Well, we know they can get at max 5 mg per kilo, so 24 kilograms times 5. They get a max of 120 milligrams here. Well, now I need to know what the concentration is. What I just figured out is 10 milligrams per ml. So basically what I can do is take that 120 milligrams that they can receive at as a max dose, divide that by that 10, and then they can receive a max of 12 mLs. So that's how much I can infuse into that laceration, which hopefully I won't need that much. Hopefully it's not that big of a laceration. But that's the most I could use before I'd have to worry about things like drug toxicity and whatnot. Okay, so just another little handy tip you may run into. I'm not going to put one of these problems onto the test. I just wanted to kind of illustrate that for you because you will see that come up occasionally. So any questions on that section, please post them up. Otherwise, I'm going to get started on the next one. I know you guys are super excited about that. Because again, I am dealing with limited time here. About 30 minutes or so, and I want to go over that the prescription assignment too. I want to go over that real briefly. So anyway, let's look at therapeutic drug monitoring. What is this? Well, basically, it's when you are trying to look at blood levels of a drug in order to help determine how much you need to give to that patient, how often you want to give it, to make sure you're achieving sufficient levels to be therapeutic. You don't get levels too high that can cause toxicity potentially. And so two terms here we're going to use, and we've kind of covered this previously, but there's peaks and there's troughs, right? Peaks is going to be peaks are the highest levels you will achieve after a given dose of drug. Trough is going to be the absolute lowest level you're going to get before you give the next dose. So for instance here, if I were to give this drug one IV dose, they get a peak level here, and then right before they get the next dose, the lowest level here is the trough. If I were to miss that dose, for instance, you can see here, this would be the new trough. Okay, whatever the lowest level is before the next dose is the trough. Why do I care about this? Well, because that ratio here between peaks and troughs help me to determine what my steady state level is going to be. And if you recall here, we can give a variety of different dosing strategies to achieve the same steady state, but that difference in peaks and troughs can make a really big difference in terms of toxicity and efficacy. Sometimes you have to give drugs more frequently at lower doses in order to achieve this sort of balance between the peaks and the troughs to keep them right in that sort of Goldilocks sort of range. There's not too much, not too little, but it's just right. And so depending on the drug, this may be important or may not matter whatsoever. And again, when do we reach steady state? Roughly 4 to 5 half-lives after you've been given a drug at a steady interval here, right? If you change the interval, though, you're going to change the steady state, right? Because then you're giving either more or less time for the body to clear that out. Again, the half-life is not changing. It's still going to take the same 4 to 5 half-lives, but if you change the dose or you change the interval, that is going to change the steady state, right? And so when we're talking about clinical pharmacokinetics, this is basically where we're using all these principles that we've been learning about this semester and trying to make sure that we're getting safe and effective management of drugs in these patients. And for a wide variety of drugs, this doesn't really matter because of the fact that they have a wide therapeutic index, right? Not a big deal. But for given drugs that have a narrow therapeutic index, this becomes pretty important. And one's in terms of getting efficacy for these drugs, but also making sure you're not going to overdo it and get a lot of toxicity, right? So we want to make sure we're getting just the right amount of drug at the site of action, the right concentration there. And so this is where we do that TDM, or therapeutic drug monitoring, basically using those serum concentrations as a surrogate to say, okay, well, if I know my blood level is this much, then I know at the site of action, I should be getting levels that are sufficient to treat that patient. So for instance, if I'm treating, say, cellulitis, for instance, with an antibiotic, I'm not going to be able to get drug levels at that site of cellulitis, but I can get blood levels, and I can correlate the two to make sure that I know that if I get this level in the blood, then I should be getting sufficient levels at that site of action in order to get the effect that I'm looking for there. And so it's important to understand the usefulness of this when it's limited in terms of utility and how we're actually going to be applying this in the real world. And so early on, this was used to help us determine what a therapeutic range was going to be. So if you look at some drugs, and you may notice this in whatever you were assigned in your drug assignment, there might have been a therapeutic range listed there where it says, okay, for a given dosage, you should be able to get between this range and this range. That's when you're going to get efficacy. Too low, you're going to not see much efficacy out of that. Too high is when you can develop high risk for toxicity. And again, if you recall, that therapeutic drug monitoring was more useful for things that have a narrow therapeutic index. So again, the wider this range, the safer the drug is roughly. And that means that even if I change the drug's dose greatly, I'm not going to really see that big of a change in terms of toxicity. But for some drugs, this overlap is quite tight. And that means that even though I'm at the efficacious range for the drug, I'm still have a high probability of causing toxicity. So this is going to be the type of drug that TDM is going to be most useful for. Things have a narrow therapeutic index. And again, depending on the drug you're seeing there, you can see that the slopes of these lines can be either fairly shallow or steep. And again, the more overlap there is, the more narrow that therapeutic index is, the more dangerous that drug is. Here's an example of a wide therapeutic index to where even though I'm getting doses up here to where I'm getting a plateau in terms of 100% of people responding, I'm still not at the point where I'm getting much toxicity, right? And again, this can be whatever toxic effect I want to define it as, and this will change depending on the drug and the side effect you're looking at. But in this case here, there's no overlap whatsoever. So this is a pretty safe drug because even if I'm dosing it to where I'm getting 100% efficacy out of that drug, you still should not see a lot of toxicity. Here's an example though, someone with a narrow therapeutic index, and this would be a good target to use therapeutic drug monitoring for, right? Something where I can actually measure blood levels to give me an idea of if I'm at that range where I'm getting good efficacy, but not so much in terms of toxicity there. So we'll go over kind of a common list of drugs here that you're going to see. But anyway, getting into it though, what factors into this? Well, the pharmacokinetic variability is going to be one of the biggest ones. And we're going to see there's certain things that we can change and certain things that we cannot. So for instance, I can't change how well a patient's liver works or how well their kidneys work, but I can change things like how much I'm giving the patient, how often I'm giving it, as we'll see in just a little bit. But based off of that drug dose and based off of the pharmacokinetic variability, you're going to get a certain concentration at that effect site. And then based off the patient's pharmacodynamics, whether they're elderly or whether they're young, whatever the case may be, you should be getting those effects there. This is what we're going to be honing in on because this is where we're going to have the most sort of variability. And this is also where we're going to have the biggest impact in terms of how we can affect it. And again, what are the sources for variation? It's everything, right? It could be if they're pregnant or not. It could be their age, genetic differences. These are all play a role in both the kinetics and the pharmacodynamics of the drug. And so in these cases here, we can combat that by looking at things like therapeutic drug monitoring. Or in some cases, we can do things like trying to dose individualize based off of genetic differences, for instance. But we're mainly going to be focusing on the blood levels, just so you get an idea of when it's useful to know that we don't do it for every single drug out there. It's pretty limited in scope, but when you are dealing with those drugs, it's really important you know how to do it and you know how to sort of interpret those values there, okay? So if you work in neurology or cardiology or any of these places, you're going to get very familiar with therapeutic drug monitoring in a lot of cases. So important considerations, again, as I mentioned, this is applying to a relatively small number of drugs. Some drugs, though, you have a direct measurement on. I don't need to look at the blood level of it. So, for instance, with blood pressure meds, I can just measure your blood pressure. That's pretty easy to do. I don't have to actually get a level of that drug to determine how well it's working on your blood pressure, right? Or I could do like a serum cholesterol for drugs that are meant for hyperlipidemia. Measure cholesterol, see where it's at. I don't have to measure the drug level, right? Or for instance, with things like blood thinner, using warfarin, I can measure the PT-INR. I don't care what the actual level of warfarin is. I care is how thin that blood is in order to prevent like a stroke from happening due to a clot forming. So depending on the drug, you may be using these other sorts of measures here. But we're going to work under a set of assumptions for these drugs that we are going to consider candidates for therapeutic drug monitoring. So the first one here is that measuring the concentrations gives you an opportunity to adjust for that pharmacokinetic variability. If the drug only comes as one dose and I can't modify that, which is rarely the case, then this would not be a good candidate. So I got to make sure that I can actually do something about the dose and how often I'm giving it in order to account for this variability. We're going to also find that drug concentration is a better predictor of response than just the dose by itself, right? This is good in the case of like giving the antibiotic or an antibiotic the same dose to two different patients, and you can find wildly different responses to that. using blood levels is going to give me a better idea of how well it's going to be working at than just the dose I give that patient there. Okay. And there should be a good relationship between drug concentration and response. That's when you establish that therapeutic range that needs to be holding true for the majority of patients there. Some people may fall outside of it, but for the most part. And so when you're looking at drug response, you're looking at exposure to that drug. Remember, this can be based off a couple of things. It's going to be based off of the bioavailability of the drug, the clearance of it, and the dosing and the interval that I'm giving. So as a clinician, you don't control this, right? You can't affect things like clearance directly unless you dialyze a patient or something. But here you do have the most sort of control over it. You can change the dose, and you can change how often the patient is going to be getting that drug. And so we'll find out how we can modify these in order to account for things like clearance and the bioavailability. So when you're looking at therapeutic range, though, for a drug, remember, this is not absolute. You can find people who will fall outside of either side of the window there, and they may be totally fine, right? It's based on the probabilities. It's based on what most people should be responding to. And so when you're looking at that range of drug concentrations, this is basically what we're saying is the probability is high that we're going to get the desired clinical response, but the toxic possibilities are relatively low. So again, you can find patients that fall outside of this. You can have patients who have a high level that is outside of the therapeutic range on the high side, and they're maybe not having any issues with it, right? That's totally fine. You don't have to do anything about that. You may have levels that are too low, and the patient is having pretty good efficacy from the drug. You still don't have to do anything about that. Ultimately, this is something you're going to hear from a lot of people, is you want to treat the patient, not the number. You want to make sure that you are taking into account how's the patient doing with the drug. Are they at a therapeutic level, but they're having all these toxicities? Even though the level's in range, that's still not a good drug for that patient, right? So you want to make sure you're taking into that account. So be aware of the clinical situation when you're looking at a level. Just don't look at it sort of in a vacuum. And then in terms of other considerations here, the range is usually characterized in a small population. So you want to consider what the study population was that made this back in the day. Some of these may be out of date. Some of these may be based off people in the 50s. And so these things change sometimes over time. It just depends. And oftentimes it can be difficult to even ascertain how valid those ranges are. It's one of those things that just gets passed down for generation to generation, and no one ever actually goes back and reevaluates that. But not great medicine, but it's kind of how it goes in some cases there. So looking at this when you're shooting for certain concentration here, basically we're going to shoot for, say, one concentration. We're not going to shoot for a range, even though that's presented to us. So what I mean by that is if a drug's therapeutic range is, say, 10 to 20 mics per ml, I'm going to go ahead and just shoot for the middle for the most part, right? So when I'm trying to figure out what dose I'm going to give, I'm just going to basically base off the middle there. And most of the time, you're going to assume your patient behaves like an average member of the population. Now, if they have things that are putting them outside of that average, then you want to take that into account. But for most individuals, they should be acting like average. Most people tend to be average, as it turns out. That's how statistics work. And then using the average pharmacokinetic parameters, then you can estimate and calculate a dose, right? So when you look at, for instance, your dose or your drugs that you were assigned, if you notice anything is dosed as milligrams per kilogram, that's based off of population average kinetics there to get the therapeutic range that you're looking for, right? And so looking at that, then you want to make sure you're dosing until steady state, right? And the idea is here, and again, how many half-lives does this take? Roughly 4 to 5. The big important point here is you want to make sure that whenever you're doing drug levels, you want to make sure that you're at steady state. And why is that the case? Well, if I'm dosing a drug here and you get one dose and they get a second dose and they get a second dose, and eventually here I'm going to be at steady state where they should be getting roughly the same average concentration here. What you're going to find is if you measure this too early, so say for instance I go ahead and get a trough level here after the first dose, this is going to look falsely low as compared to if I waited the patient was at steady state, and this may lead me to think that the level's too low and I'm going to give more drug to account for that. That's going to be a big pitfall that a lot of early clinicians run into. Make sure you're dosing until steady state. And that's why I always kind of hammer in, why do I care about steady state? Because you want to make sure when you're doing these blood levels, you're giving the patient time to achieve this before you decide to make any changes. Okay. Anyway, so say you get your level back, and you get one scenario A here where they get adequate response, patient's responding well to it. If you're giving an antibiotic, the patient's fever's coming down, their white count's coming down, clinically they look better. You just continue treatment, everything's good. Scenario B, though, let's say you get a level that comes back either subtherapeutic, say below that range, or in the toxic range, at that point, then I can start to manipulate things. I can look at changing the dose or the interval, because again, I can't change clearance of the patient in order to account for all that to make sure I get back into the range. And so why do I use concentrations here? Again, it's providing me extra information, right? I'm using it in conjunction with clinical data. I'm using it in conjunction with the patient's status. So like, how's their kidney function doing in conjunction with this level? How's their white count doing? How's their fever and all of that? And this helps us to provide the basis for individualizing that dose for that patient there. So that way you can take these average population kinetics, get the levels from your particular patient, and now I can individualize it based just on them, okay? And again, it's more labor intensive than using population kinetics, but this is why it's important for those things with a narrow therapeutic index, right? And again, one of the big things you want to check too is, have any changes occurred here, right? So why is this patient responding differently? Is it due to their physiologic status? Are they dehydrated or fluid overloaded or in renal failure? Or is there maybe an interaction happening here? Maybe there's an herbal drug on board that is playing a role that is either inducing enzymes or inhibiting them or whatever the case may be. And then also adherence, like, are the patients even taking the drugs like they're supposed to? Did they miss a dose? I'll frequently have issues to where even in the hospital, do you think where nurses are always giving the doses, they should have no problems with adherence? Well, sometimes we run into issues where patients maybe have to go down to the imaging department, have a CT done or an MRI done or something like that, and then they miss a dose because they're out of the unit for a couple hours. Things happen, right? Things happen where people are not taking the dose that they're supposed to. Now, let's look at some common reasons to request drug concentration. So you may want to do this, and typically we don't do this just routinely. There's a few drugs we do it all the time, but in some cases you may do it if you think toxicity is happening. You want to get a level to see, okay, well, the patient's having the side effect, maybe the level is too high. This is where that can be useful. Or is there a lack of therapeutic response, right? So if they're giving a drug at a normal dose and they're still not responding to it, that may prompt you to go ahead and get a level at that point. You may check a level to see if they're adherent to their drugs, right? We do this all the time. If you have a patient who comes in, say, for instance, they're seizing, and they're coming into the ER, having a seizure, frequently we'll figure out what they normally take for their seizures, and then we'll get a blood level to see, are they actually taking it or not? Quite frequently, they have not been, their level will be 0, and that explains why they're having the seizure. So we go ahead and just load them up with more of their drug than they're normally taking, and that usually takes care of it. Or in some cases, you may find that the level was normal, but they're still seizing. Well, that means that drug's not really working all that well for them anymore. Maybe now we need to add on a different drug, for instance. So you can also do levels if you have changed the dose in therapy, and then you want to go ahead and check to see how that's worked for your patient, see how it's actually changed your level, or maybe if the clinical status has changed. Maybe their kidney function has gone down, maybe liver function has gone down, and then check for potential drug interaction. These are common reasons why you might request to get a drug concentration, actual plasma concentration of that drug there. Now, some things you want to use in order to interpret serum levels, because again, you want to look at a number in a vacuum that doesn't really tell you a whole lot. You want to know things like, when was the blood sample taken? Was it taken in the morning, at nighttime? In relation to the last dose given is really important too. Was this a peak level that I got? Was this a level taken right after the drug was given? Or was it a trough level? Or maybe is a random level somewhere in between? You want to know what dose they were actually taking and how often they were taking it. You want to know patient demographics. You want to know how their age. You want to know their size. You want to know all these things. Also, concurrent medications and maybe interacting. You want to know the reason that you're monitoring. Is it because you've made a recent change? Is it because you suspect toxicity? And then you also need to know, well, if I get a level, what's the actual range I'm looking for? If you get a level and there's no established range there, it doesn't really help you out a whole lot, because you get a random level and it's like, okay, well, I don't know what to actually compare this to. And so these are all the points you want to know when you're trying to interpret the actual level that comes back. And so what you're going to find is that some common drug characteristics you're going to see for drugs that benefit from TDM or benefit from serum level monitoring is ones that have no clear observable therapeutic or toxic endpoint. What do I mean by that? Is basically you can find that along that spectrum that the efficacy and toxicity kind of go hand in hand, and so it can be difficult to really find that little that kind of that narrow point where you're getting the efficacy but trying to minimize that risk of toxicity there. So when there's no clear endpoint here, that can be a good one to use serum levels for. And again, we're using this as a concentration, or the concentration as a surrogate for what's at the actual site of action. So it may not be perfect, especially if there's differences in kinetics like volume distribution and things like that, but this is what we're using it as. And then again, these should be narrow therapeutic drugs, right? Maybe they have pretty variable pharmacokinetics. Like for instance, certain antibiotics like gentamicin, we do this too all the time because we know that there's inherent variability in the kinetics for patients, whether it's their renal function or their volume status and things like that. So we just know that because of that narrow therapeutic range being affected by their kinetics, we have to monitor for that. Otherwise, we're likely to give either too little and not treat the infection or give way too much. So these drugs should also have some risk associated with toxicity. So for instance, with gentamicin, if I have too much building up in the body, that can lead to ototoxicity, right? They can have hearing damage. They can lead to nephrotoxicity, can lead to kidney injury. Or lack of response and lack of efficacy can be also problematic. If I have a patient I'm treating for sepsis, they have a bloodstream infection, and I don't get levels high enough to treat that infection, that patient may die from that. So these are other reasons why you want to make sure you're not developing toxicity, but also you're getting that response you need in order to make sure you're doing right by that patient. And also, we should find that once you get to that level, the drug should be having a pretty stable pharmacologic effect. So that way, when you get into the range, you know that, yeah, this is the right range for this patient. The drug's going to work as I intended to. So, and typically when you're looking at this, you want to make sure that your drug assay is going to be accurate, precise, and specific. And what I mean by that is basically that when you actually measure the level for that drug, that it is accurate. So for instance, oftentimes people will do urine drug screens to look for illicit substances. May not realize that those tests may not be real precise or specific in some cases. So for instance, if you do say you take a dose of pseudoephedrine, you might test positive for amphetamines. Doesn't mean you're taking crystal meth, it just means that you took a dose of Sudafed, you had some sinus issues. So the tests we're using, we want to make sure they're actually going to be specific for that particular drug. So that should be expected. There should be a reasonable turnaround time. So for instance, you don't want it to take 2 weeks to get a drug level to come back, right? So you're typically doing things that are easily measured at the lab that you're doing it at, whether it be in the hospital or if you're sending it off to Quest or wherever. You should have a reasonable turnaround time. So that way, when that level comes back, you can make that change for that patient in terms of how you're changing their dose or the frequency they're receiving it. And hopefully it's going to be relatively inexpensive. Sometimes people want to get levels on drugs that, one, doesn't really have a good therapeutic range, and then it's incredibly expensive, and they have to send it off to like the Mayo Clinic or something. It takes 2 weeks. That's not great. We want things that are relatively quick and cheap, as in most things in medicine for the most part. And just to give you some examples of commonly monitored drugs, we have things like anti-infectives, things like vancomycin or aminoglycosides. Don't memorize this list. I'm going to talk about these as we get to them next semester. But just know that there's a lot of drugs here. It's a relatively small list, but there's many different specialties you might go into where you're going to be using these more or less often. So for instance, if you go into transplant medicine, you're going to be seeing a lot of immunosuppressives like tacrolimus. You're going to want to get levels on and be able to interpret that, and you'll get very well accustomed to doing that sort of thing. But cardiovascular drugs, anti-epileptics, anti-infectives, these are kind of our bread and butter drugs we do a lot of therapeutic drug monitoring on. And again, if you look in a hospital and see just the number of patients on some of these drugs like vancomycin and the aminoglycosides, you understand why this is so important, because so many of them are getting this in a lot of cases. So there are some limitations to it, though. So for instance, cost can be an issue. If getting levels is costly, that can be a problem there. If the drug has really wide therapeutic range, it doesn't help us to get a level because it doesn't really tell us a whole lot. Or if we don't really know a good relationship between the concentration and the response. Frequently, providers will want to get a level for a drug that has no therapeutic range. And they're like, well, I just want to get it. I just want to know. Okay, well, if it doesn't tell you anything, what was the point of doing it in the first place? And a really good rule of thumb to remember for you as practitioners is if a level or if a lab is not going to change your management for that patient, there's no point in getting it in the first place, right? So if you get that information back and you're only doing it because it makes you feel better, that's not a good reason to do it, right? You want to make sure that that information, when you get that back, is going to lead you to make a decision about something. Am I going to initiate a treatment? Am I going to change the dose of something? Those are the reasons why you want to be doing these labs in the first place. And again, if you have a direct response measure, you probably don't need to get a level for that drug. So for instance, if I am giving a patient antihypertensive, I can just monitor their blood pressure, right? I don't have to actually get a level of that drug in order to determine how well it's working. I can just measure the blood pressure. So I think I'm going to cut it here, and I want to talk about the prescription assignment. We'll talk more about this a little bit in the last section, but just because I'm going to give you some time to actually work on that, because I think I have about a week after today to do that. So if you don't mind, I'm going to stop this. If you have any questions, please post them up in the chat. I do have one question here on the sticky board real briefly. It says, because neonates have a higher concentration of hemoglobin, does this have any effect on drug distribution? Not necessarily. You're going to find hemoglobin itself does not have a role to play. It doesn't really directly bind many drugs, but more so like those tissue proteins and plasma proteins we mentioned being altered. That's going to have a bigger effect on distribution there. So not a big effect. Okay, so let me pull up the prescription actual assignment itself. So I'm going to go into your assignments, and then I'm going to go to prescription writing assignment. Okay, so there's a couple of documents you'll see here. Let's look at these. So you have your, the most important one's going to be the rubric here. Let's just open that up briefly. All right, so here's our rubric. So for this one, you're going to see there's two main sections here. There is the prescription writing portion. So this would be like if you were writing a prescription for a patient to fill at a CVS or Walgreens or wherever, okay? There is another section here that is going to be for medication orders. This is going to be more so if you are writing something in the hospital. We will do this next semester. You just want to focus on this first one up here, okay? This is what we're going to be doing for this particular assignment, okay? This is an example of what a typical prescription would look like. And these are all of the points that it should include here, right? Now, one thing I will say, for this prescription assignment, I want all of this to be handwritten when you turn it in, okay? Don't pre-fill anything out. I want you to actually physically do all of this. And you're like, why would I want to do that? That's ridiculous. Again, I think by physically writing in all of this stuff, it helps you to kind of commit to memory those components that you need to make this a valid script. And again, this will come up more so in the last section here, but again, I want to give you some time to think about this stuff. So this is all the details you're going to need on a typical prescription, and it will be referenced here in the specific components here. These are the things you're going to get points for, or for missing, you may have points removed here, okay? So basically, in another question too that comes up, when I say handwritten, you can do this on an iPad with a stylus. That's fine. I can kind of tell the difference. If it's like a cursive font like this, I will not accept that. I just did this for your benefit here, just to give you an idea what this looks like. Okay. So actually, I want this handwritten. Either write it down in ink on an actual piece of paper and then scan that in and then turn it in. Or if you want to do this digitally with you writing it yourself, that's fine as well. I'm not really going to give too big of a care about that. So anyway, so looking at this, here's the things you need to put into this prescription. And I'm only hammering this in because this is something I hear on the feedback, because I don't really go through this enough. I just expect you to read it and then know it, but I want to make sure I actually go through it with you. So make sure that you're including the name and address of the provider. If you want to make up your own provider name, I'm totally fine with that. The more jokes you put in there, that can be humorous as long as it's appropriate, professional. You want the patient name, date of birth, and address. This helps you to ensure this is the correct patient, right? The medication name and strength. This has to be a commercially available product. What I mean by that is when you look it up, it has to be something that is commercially available. If you say, I want to give 250 milligrams of this drug, but it only comes as a 30 milligram tablet, that doesn't really make sense. It needs to be a commercially available product. So what does it actually come as commercially? You can find that in plenty of drug references, okay? Then your instructions to use. This is the biggest component here. You want to make sure that you're seeing how much to take, when and how often to take it. You want to see the route of administration. So is this oral, IV, etc.? I want you to include the indication for why they're taking it, because this can be really important to help other providers determine, is this appropriate or not. So this helps your pharmacist to know, okay, is this the right dose? Because you may find that for different indications, you're dosing it differently, right? So that's important. And then if it's an as-needed medication, the indication for that. So for instance, if it's a pain medication, you want to write, say, ibuprofen, PRN, pain. So that way I know why they're taking it as needed, okay? Then you have to have your dispense quantity, which needs to make sense for the instructions. So for instance, if it's a tablet you take 1 time a day, and I'm writing for a month's supply, then you want to write for 30 tablets, okay? And then refills here. So if the refills are appropriate, then you would do refills. If it's 0, make sure you put 0 refills. the date written, and then your signature with the appropriate credentials. Okay, so if you're a PAS1, you just write PAS1. If you're writing as an MD, write MD. It doesn't really matter to me. So you can see all these components here, right? So I have the provider's name, address. I have the patient's name, date of birth, and address here. I have the date the prescription was written. I have the name of the drug. I have the dosage form that's available, the strength here, right? And then I have the instructions. Take 1 tablet daily by mouth with meals. So that's a special instruction for that, for glucose control. You could say for diabetes. You could say for whatever. Quantity, 90 tablets. Refills 3. So I'm doing a 3-month supply and writing for 3 refills. Now, a lot of you are going to come to me for different prescription assignments and say, well, how many refills should I do for? How many tablets should I write for? How many? These are things I want you to figure out by actually looking up the information yourself, right? This is part of the actual assignment itself, is trying to learn how to find this information for yourself. Now, the assignment that you have for this time is going to be a little bit easier because I kind of give you all the details here. So basically, for this one, I've already kind of told you what to do. So I'm already telling you for these 2 patients here, okay, presenting to urgent care clinic for developing pain in the left great toe, he's got gout. You're going to do a 7-day course of meloxicam Mobic. So what you need to do is be able to go and look up the drug meloxicam and figure out what an appropriate dose is for a 7-day course for this patient, right? So you already know the duration. You just got to find the dose to administer based on what's available, okay? So I'll give you an alternative example. Instead of meloxicam, I could do like another type of NSAID drug. So let's do... So let's say I got the drug Celebrex here. So this is celecoxib. This is a similar drug to meloxicam. So basically what I would end up doing if I was looking for like a pain indication, I would look at one of these indications. I would look for what kind of matches the indication that I was looking at. So let's say, for instance, acute pain or primary dysmenorrhea. Well, this sounds like this guy's in acute pain. So what I could go ahead and do is look at this dose. And I could say give 400 milligrams on day 1, and then I would do 200 milligrams twice daily as needed for pain. Right, so you could look that up and basically determine how to write that down. If you see a range of doses listed here, you need to pick which actual dose you want to give. You need to be specific when you're actually giving a dose. When I mention using something that's commercially available, what you can do if you're on one of these sections here, and again, you can find this in up to date because again, this is the same database essentially. There should be a dosage form section. You want to go to dosage form US because we're in the US, and you can see here, this is how it's available. I have 50, 100, 200, and 400 milligram capsules. So I would want to write for one of these when I'm actually doing my prescription. If I were to write for a 250 milligram dose, that really wouldn't make a whole lot of sense here. No one's going to do Celebrex 200 capsule and then a 50. That's not really necessary. So pick one of these that's commercially available based on the dose you're going to be administering to that particular patient. Okay. On the other hand, here, and I'm always going to include one of these because I always think it's really important to do pediatric dose calculations. Here you got a 4-year-old, they're 18 kilos, they have strep, and you're going to give them amoxicillin. So here I'm already giving you the concentration. I'm already telling you the dose they need to get, mg per kilo, once daily. Again, when you're doing your quantity, this is going to be in mLs. You got to figure out how many mLs you're actually going to dispense based off of that. Okay. So those are kind of the key points I want you to take away when you're doing this assignment and turning it in. I expect you to work on your own. I know people talk, and there may be some exchange of ideas here, but everyone's expected to do their own work. And I can often tell when people are working together because I see them making the same mistakes. So it's always kind of funny because I can see, okay, I know these 3 people work together because they made the exact same mistakes as one another. That really try to do independent work here. I can usually tell the difference. Okay, so Nisha says, so I already turned this assignment in, but if a recommendation states more than once a day on LexiComp, should we have done it that way? For which drug specifically do you mean? Oh, for the Mobic one. Right, so I did not tell you a frequency here, so if it says to do it more than 1 time a day, follow that instructions for what's in the reference. So if it says do 3 times a day, 4 times a day, whatever the indication you're using, it needs to be consistent with that. And if you need to resubmit it, that's totally fine. You can do that. But so any other questions on that? I think I kind of walked through the majority of things. I'll probably get some more questions. I think this is due on the 31st, which I think is let's see, I have a question over here. Okay, I'll talk about that in a second, but I think yeah, this is due July 31st, so you'll have a week to do that, so you can start working on that one. So someone asked, even though a drug has a wide therapeutic range, is it possible to have a toxicity cutoff number that can be used to monitor a drug, right? Generally speaking, if a drug has a wide therapeutic index, the dose would have to be so high to consistently get that toxicity to happen that we wouldn't necessarily have a number established there, or we would just not do enough therapeutic drug monitoring to have that range sort of established. So it's possible you get a number back. So if a patient is having that toxicity, you measure a level, but if it doesn't really correlate to anything else, if that study's not been done, then we don't really know what to do with that number. Most of the time, you just see that patient is developing that toxicity and then reduce the dose to see if you can deal with it, or change the drug out altogether in some cases there. So Josh was asking, are we just doing these 2 prescriptions? Yes, for this assignment, you're just doing these 2. In the future, I will always end up having 3, but to kind of break you into it early, I want you to just do these 2, just so you get a feel for it, you get the process down for how to do these. In the future, I will sometimes leave more up to you. So you may find in the future I'll do assignments to where you have to select the drugs. I won't even tell you what drug to do. I just say, patient weighs this much, they have this indication, go for it, right? But here I'm trying to spell out as much as I can because it's early and I want you to get the process down. Do you just want to include a reference page or a section? No, you don't need to do that. I will know if it's appropriate or not based off my references, so you don't need to include a reference on that. But thank you for that question. That was good. What other questions can I answer for you all? Nothing at all. I only see 27. I'm surprised I don't see the full 30. So if your friends are not here, I would encourage them to please watch this in real time, or as close to real time as they can after this, so that way they can get caught up. But if nothing else, just double check the sticky board real quick. So nothing else here. Yeah, so if you have any questions that come up, please let me know. I'll be grading your drug info assignments over the weekend, most likely. So it'll be fun for me. But hopefully y'all have a safe and healthy weekend, and I will see you next week. Thank you all. Yeah, David, yeah, you're just going to use the blank page on the rubric and use that for the 2 prescriptions. Yep.